Good morning. I think we're getting ready to start. My name is Anna Wald. I'm on the infectious disease faculty, and I'm actually the head of the division of allergy and infectious diseases. And it gives me, in that role, it gives me a great pleasure to introduce Dr. Kathleen Neuzil, who is here visiting in honor of Dr. Bill Kirby, who is a long-term faculty member at the University of Washington in infectious diseases, and I think Kathy will say a few things about Bill. Kathy originally trained in the University of Maryland, subsequently got her MD at Johns Hopkins, and did her internship, residency, fellowship, and PhD, etc. at Vanderbilt. Subsequently, we were actually lucky enough to have her here, and she was on the faculty for, I think, just over a decade. And subsequently, she left to work at PATH in the role of director of a vaccine center there. Right now, she's moved back to University of Maryland, where she's professor in the Department of Medicine, director of the Center for Vaccine Development, deputy director, Institute for Global Health, and chief of Division of Geographic Medicine. Kathy has many publications and long list of achievements that I'm hoping she will share with you today. Thank you for coming.
So thanks, Anna. It's really an honor to be here and just a lot of fun to be back and see a lot of old friends. You know, I was trying to remember the last grand rounds I gave, and I think it was when the first zoster vaccine was licensed, and I gave a grand round on zoster, and 10 years later, just to make a pitch, we have a new adjuvanted zoster vaccine, and so life has really changed. I'm going to talk to you today about vaccines, antimicrobial resistance, and health equity, and it really is my honor to give this lecture in the name of Dr. Bill Kirby. I unfortunately came to the University of Washington in 1998. Dr. Kirby died in 1997, so I never had a chance to meet him. I did have a chance to meet and work somewhat with Dr. Petersdorf, who wrote this very eloquent tribute to Dr. Kirby when he died. And just to point out his really unparalleled contributions to early antibiotic discovery, and of course his major role in the forming of the Department of Medicine here, the Division of Infectious Diseases here, and we really all owe him a debt of gratitude for the legacy he has left. And, you know, arguably, I hate to admit it, at the University of Maryland, but the best infectious disease training program in the country. And again, I think you're very, very fortunate to have Anna leading you at this point. So what I'm going to talk about today, and I promise you it won't be boring, is I'm going to talk about vaccine impact beyond efficacy. And I'm going to use two examples, rotavirus and typhoid vaccines. And if you're wondering why an internist does a lot of work on pediatric vaccines, I will remind you that there's probably no better way to prevent adult disease than by ensuring that children don't get sick and transmit these viruses and bacteria to us. And we've been reminded of this many, many times. I think the pneumococcal conjugate vaccine program is one of the best examples where we have unprecedented decreases in adult disease when we instituted a childhood vaccination program. So since I brought up equity, just a few background slides for those of you who don't think vaccines every day. So what are some equity principles when we talk about vaccines? Well, vaccine delivery systems throughout the world are designed to reach every individual, regardless of socioeconomic status, geography, age, gender. These are some pictures of a program that we ran in Senegal for about 6 years. We are literally vaccinating children outside, under huts, where it's convenient, in the middle of the village. We, of course, know that hospitals, clinics, curative care are limited by the requirement for fixed structures, for trained healthcare personnel, and so access really becomes an issue. I think the other important point is financially, vaccines ensure equity. So domestically in the United States, we do have universal health care for vaccines. We have something called the Vaccines for Children program, or the VFC. And this is an entitlement program that guarantees vaccine for all children in the United States until their 19th birthday. So underinsured, uninsured, if the Advisory Committee on Immunization Practices recommends a vaccine, children in this country get that vaccine. Now, those of us who are internists have been arguing for many years that it probably shouldn't stop at the 19th birthday, but we are very happy with this achievement, and we've had landmark achievements because of it. Now, internationally, in about 2000, a similar program was set up for the world with the founding of Gavi, the Vaccine Alliance, the Gates Foundation, some of the Scandinavian countries, the UK, the US government were very instrumental here. And what Gavi does is it subsidizes vaccines in the world's poorest countries. So for example, a rotavirus vaccine that costs us $120 a dose, and it's a 2 or 3 dose vaccine schedule, has a 30-cent copay in these poorest countries. So this enables them financially to be able to introduce vaccines. So let's go to our first example, which is rotavirus. So you might say, what is rotavirus? So rotavirus was actually discovered in the early 1970s by this woman, Ruth Bishop, in Australia. And she discovered this virus when she looked at the duodenal mucosa from children with acute gastroenteritis. I'm not sure if I have a pointer, there we go. And saw these wheel-like virus structures, which is where the virus, rotavirus, gets his name. And this was really a remarkable discovery, because before, Dr. Bishop worked at Royal Children's Hospital in Melbourne. Before the discovery of the virus in 1972, the majority of children admitted to the Children's Hospital with acute gastroenteritis had unknown etiology, which you see there, about 88% were unknown. There was some salmonella, some shigella, some of the bacterial agents you would expect. 2 years later, using electron microscopy to diagnose, to go backwards, I gotta get used to this pointer, 52% of children admitted to the hospital had evidence of rotavirus. So we learned very quickly in etiologic studies around the world that we've all been infected with rotavirus by the age of 3, that it's a democratic virus if you go to the United States or if you go to the poorest countries in the world. About 40 to 50% of children hospitalized with severe dehydrating diarrhea have rotavirus. And I've just used this example from a number of countries in Africa. It's also a democratic virus because even with improvements in water and sanitation, we still saw rotavirus. This is some work from my colleagues at the University of Maryland Center for Vaccine Development, and this was a large study in 7 developing countries that actually was a case control study, because people started to say, well, you're seeing rotavirus, but how do you know that it's the causative agent? And they found that rotavirus is very, very rare in community controls without diarrhea, and that if you look at attributable risk, rotavirus is the #1 cause of severe diarrhea in the first year of life, the #1 cause of severe diarrhea in the second year of life, and the #2 cause of severe diarrhea up to the age of 5. So hopefully I've convinced you that this is important. So back when I started to work on rotavirus, and this has now been a decade journey for me, we had no recommendation for rotavirus vaccine in countries in Asia and Africa, where 500,000 children, it was estimated, were dying from rotavirus. In the United States, and this is an example of an access issue, Certainly 40 to 50% of children in the hospital had diarrhea, but because they had access to care and access to hydration, they weren't dying of rotavirus. So this is an example of an equity principle where we had access to a vaccine and they did not have access where they needed it most. So the World Health Organization said, well, we should be using rotavirus where it's been tested, but we're a bit skeptical, actually, that rotavirus vaccines are going to work in the developing world because other oral vaccines haven't worked well. You know, oral polio, you need more doses. Early oral typhoid vaccines didn't work well. And so, you know, you have to prove to us that this vaccine actually works. So these were the two rotavirus vaccines that we had available in the US at the time, and they're still the two rotavirus vaccines that we use in our routine immunization program. They're both oral live vaccines. They're based on different strains of the rotavirus. They had been tested in very large clinical trials. An earlier vaccine had been associated with intussusception. They had been shown to be highly efficacious, 85 to 100%, depending on what outcome definition you used. So again, these vaccines were being rolled out across the United States at this time. So we were charged, we received a very large grant to design and execute clinical trials that would inform policy and financing decisions. Now remember, these vaccines are already licensed. Biologically, we know that they work. I've just shown you the data. They worked in clinical trials. They were working in the United States. So this question was really different. The World Health Organization was saying, but will they work in field conditions in these places where children are dying of rotavirus? And so we had a number of questions to ask, of course. You know, which vaccine should we use? Where should we go? You know, people always want vaccines in their population. Well, we can't do vaccine trials in 7 billion people. So we tried to pick populations that will be generalizable to other populations in which the vaccines will be used. You know, what should our outcome measure be? What are the logistical considerations? You know, it may be nice to go to the country that has the highest diarrhea mortality, but can we actually do a clinical trial in a country like that? There are political considerations. There are all sorts of considerations. So we ended up designing and implementing 3 large randomized clinical trials involving over 12,000 children. You can see the countries here. We were actually the first to test these vaccines in countries with high prevalence of HIV infection in moms, because we knew this would not be generalizable to sub-Saharan Africa if we didn't include HIV infected or exposed children. We included, you know, Mali, Malawi. These are some of the poorest countries in the world where we went to do these trials. We also tried to implement these trials again in a way that the vaccine would be implemented in the field. So in most of the poor countries in the world, vaccines are given at 6, 10, and 14 weeks of age, as opposed to the United States. Our vaccine schedule is 2, 4, and 6 months of age. And that's for a number of reasons. These children are exposed to diseases earlier in life, and it's also, even vaccines are not as accessible as children get older. Moms do not bring them to clinic as often. Now, we knew this was really interesting. There were studies that had been done. This is an oral vaccine. They're using oral poliovirus in these countries. We absolutely knew from phase 2 studies we had done that there was interference. So we knew that oral poliovirus was going to decrease the immunogenicity of our rotavirus vaccines. But we also knew if we didn't use the routine immunization schedule in these countries, that the vaccine wouldn't reach the children. So we said, you know, we're going to give it at 6, 10, and 14 weeks. We're going to give it with oral poliovirus, which was not done in the US and Latin American studies. I've already said we didn't exclude HIV positive infants. Some people thought that breastfeeding would interfere with the take of an oral vaccine, and we said, you know, we are not going to tell women not to breastfeed. In public health, we've made that mistake before, and we were not going to make it in our rotavirus vaccine trials. And we focused on severe disease. As I said, everybody gets this infection by 3 years of age. We weren't trying to keep children from being infected with rotavirus. We were trying to keep them from having severe disease, ending up in a hospital, and dying of rotavirus. So these studies, this is the early part of my story, have all been published. And here's just a summary of a lot of work and a lot of data and what we found. So what we found, if you look at the confidence intervals, was actually remarkably consistent. We found efficacy estimates between about 50 and 65%. So remember, in the US and Latin America and Europe was somewhere between 85 and 100%. And remember, the definitions are a bit different. We're giving these vaccines at an earlier age. We're giving them with polio. We expected somewhat lower efficacy, but we're in the 50 to 65% range. And initially, people, I believe, were somewhat disappointed with these findings. Now, if you put these findings in perspective, and some authors did, this was a review published in Vaccine in 2014, they've said, you know, the rotavirus is of intermediate efficacy. It's somewhere in this red range where, you know, we would call this a failure or equivocal as compared to what we're used to with vaccines, which is, you know, 90+% efficacy for many, many of our vaccines. However, we know that efficacy is a relative estimate. I like to say, if you have a choice to take 90% of my net worth or 60% of Bill Gates's net worth, 60% is much better than 90% in that situation, and I would advise that you go for Bill Gates. So we applied this principle to rotavirus vaccine. And we said, and actually this was one of our primary outcomes, this was not post hoc, we said, how much disease is prevented by these vaccines? And when we looked, for example, at South Africa, which is moderate socioeconomic, compared to Malawi, which is one of the poorest countries in the world, we saw an efficacy of 77% in South Africa and 50% in Malawi. But when we looked at the incidence of severe disease in the control groups, we saw an incidence of about 4 per 100 in Malawi and in South Africa, and about 8 per 100 in Malawi. In the US, we have about a 1% incidence of severe gastroenteritis. So the burden of illness, you can look at case control studies, you can look, but this is vaccine as probe. The burden of illness of severe rotavirus gastroenteritis was 10 times higher than we expected it to be. So even with a 50% efficacy, for every 100 children we vaccinate, we're preventing 4 cases of severe rotavirus gastroenteritis. We prevent about a half a case in the US for every 100 doses of vaccine we use. So let's apply this public health principle rather than the efficacy principle and look at how vaccine-preventable disease incidence compares to other vaccines, which is rare. Invasive pneumococcal disease is relatively rare. This is a very common disease. Then you would call the rotavirus trials a success. And fortunately, the World Health Organization agreed with us, recommended the inclusion of rotavirus vaccines into infants throughout the world. And I'm very happy to report that these countries have adopted these vaccines. And you can see here the blue are the non-Gavi eligible, and Gavi is that organization that subsidizes vaccines. The green are the 73 poorest countries in the world. So if you see the green, those are the poor countries that have introduced rotavirus vaccine. So this is a success story in itself, but of course, our goal isn't to introduce vaccine, our goal is to prevent disease. So it was really interesting because just this year, with a new rotavirus vaccine made by a developing country manufacturer at a lower cost, so it's vaccine very similar to the Merck vaccine that we use, was tested in Niger. And what they found was right about a 69% efficacy, which is very similar to what we saw, 65% in Africa with a similar vaccine against severe gastroenteritis in children in Niger. So while I argue we need to use rotavirus vaccines and 65% is enough, we're still not preventing about a third of disease. So we can still do better. And again, this has been a consistent finding. So how can we do better? First of all, most people assume that what we find in clinical trials under ideal conditions is the best that we can do. And perhaps for drugs and other interventions, it might be. For vaccines, that might not be true. So let's just take a look at this. You know, what could adversely affect, what could make our efficacy and disease prevention estimates go down when we introduce into the field? Well, we're giving the vaccine to the entire rather than a select population, which means it could include children with poor immune responses. We did not think this would be a big factor in our trials because we included really any child that was not acutely ill at the visit. You certainly have less controlled storage and transport conditions. This is a live attenuated vaccine. There are cold chain requirements, and absolutely in our clinical trials, those are monitored in a way that they're not going to be monitored when this is taken into the field. We're also going to have children with missed vaccine doses. You know, they're not going to miss doses in a clinical trial, but in the real world, they're going to miss doses. But actually, could we do better when we go into the field? Well, again, we've seen time and time again that we have done better with vaccines when we go into the field. We're vaccinating a relatively small number of children in a community. We're very unlikely to see indirect effects in the context of an individually randomized trial. But certainly in higher resource places, including the US, we saw the near elimination of rotavirus at a vaccine coverage rate of about 70%. So we were quite optimistic that we actually might see more of an effect when we introduce these vaccines. We actually thought it would be good if we didn't follow the strict criteria of our clinical trial. It would be good if children actually came a little bit late for vaccine because they would probably have less maternal antibody interference. And we're seeing, of course, the rollout of inactivated polio virus throughout the world. So I've been very optimistic that in addition to eradicating polio, by switching from oral to inactivated polio, I think we're going to see a real benefit in terms of rotavirus prevention. So what did we see in the US? So in the US, we saw a reduction in gastroenteritis hospitalizations among children and adults, actually, too young or too old to be vaccinated. So again, this told us we were seeing indirect effects and that these youngest children were actually more important in the transmission of rotavirus than we would have guessed. We actually did not have a mortality outcome in our trial. I think you can appreciate this. We felt like these children were part of a clinical trial. We were doing active surveillance. If we identified a child who was critically dehydrated, we made sure they got to the clinic. In a field situation, that child is likely to die. So what did we see? You see the arrow there with countrywide introduction of rotavirus vaccines in Mexico. For the first time, we saw an effect on mortality. So what you're seeing here in red, this is really fascinating. This is an ecologic study. You're seeing diarrheal mortality. The red peaks are in the winter. So there is a very strong seasonal association with mortality with the rotavirus season. As the 1-year-olds, that birth cohort was being vaccinated, we saw declines in mortality in the 1-year-olds, but not in the 1 to 2-year-olds who weren't yet using vaccine. We get to the 2nd year of the program, we now see declines in the 1 to 2-year-olds, and then we see some declines in the older children, but there's not a lot of death in the older children. So again, this was very powerful evidence that rotavirus vaccines could affect mortality. And similarly, in Africa, we saw hospital admissions for diarrhea decrease after the introduction of RotaTeq in Rwanda. Now, these studies are much easier to do in places where you have seasonal disease. This is true of influenza as well. In many parts of the world, we don't have this highly seasonal disease, and these ecologic studies become much more difficult. So what we did, and this was published this year, is we went into Bangladesh and did a cluster randomized trial, which allowed us to see, by giving some clusters rotavirus vaccine and other clusters, just so you know, Bangladesh hadn't yet introduced vaccines, so we did not consider this to be unethical. We did not withhold a vaccine from these children, but we actually introduced ahead of time in certain clusters, didn't introduce in the other clusters. They've all now received rotavirus vaccine. And we looked at the comparison to see if we would have indirect effects. And to our disappointment, with a coverage of about 74%, which is about where we were in the US when we saw indirect effects, we did not see indirect effects. This is overall efficacy was about 30%. Now, overall is going to include children who were and weren't vaccinated. If you looked at just the children who got vaccine, the direct efficacy, it was about what we had seen in the trial. So we weren't really seeing indirect effects. And, you know, it's unclear why. We hypothesize a number of reasons. I'll talk about one important one. We know that vaccine is not as immunogenic in these populations. That's a fact. We've shown that from multiple immunogenicity studies. You know, rotavirus is circulating year-round. The force of infection is likely much higher here. We still hope we see indirect effects, but it will likely take either a more effective vaccine, higher coverage, or potentially both. But we did not see it in Bangladesh. So if we look at immunogenicity, you know, this is really remarkable. This was from our original trials. The numbers almost don't matter. The point here is, at birth, these children have astronomical levels of antibody that are not seen anywhere else. And this was neutralizing antibody, and this we can assume is maternal antibody. So if you're a child in Ghana and you get a rotavirus vaccine at 6 weeks of age, and you get your last rotavirus vaccine at 2.5 months of age, and we look at your antibody at 4 months of age, it's actually lower after your third dose of vaccine than it was when you were born. So this is the significance of maternal antibody in these places. Now, if you don't get vaccine, it's much, much, much lower. So vaccine is doing something. But we believe this issue of maternal antibody is highly, highly significant. Fortunately, it protects these youngest children. And if you look at rotavirus, it's very rare in the first couple months of life. So we said, you know, why are we using a US schedule to administer rotavirus vaccines in Africa? We know they have weaker primary antibody responses. We're seeing evidence of waning of protection, which we don't see in the United States. We know, and I showed you the data, that the burden of disease still remains high in the second year of life. And we know that the World Health Organization does allow administration of rotavirus vaccines up to 2 years of age. Now, this is part of the primary series, but it doesn't preclude us from giving a booster dose of rotavirus vaccine as we do with many other vaccines. So we did that. We actually went into Bangladesh and Mali and gave a booster dose of vaccine at 9 months of age. We did it at 9 months of age because that's when children come for measles. I think 6 months of age would be a great time. I've said in highly seasonal areas, I would do a rotavirus booster campaign before the season in the same way we do it for influenza, right? Just go out in September and give all of these kids an extra dose of rotavirus vaccine before circulation of the virus. So what we showed is that we did get a boost here in antibody at the 9-month time point. If you looked at averages, it actually wasn't remarkable, But what we were pleased to see is that the boost occurred at the children with the lowest antibody levels. So we didn't take high antibody and make it higher. We took children with very little antibody and made it higher. Now, I mercifully am not showing you all the work we've done to try to identify a correlate of protection for rotavirus vaccines. We've done modeling work. You know, in the US, we couldn't identify a correlate because you can't identify a correlate when you don't have any failures. We thought, wow, you know, half of our children are failing, we'll be able to find a correlate. There's no individual correlate of protection, unfortunately. I can't tell you if you have, you know, an antibody of 20 or greater, you will be protected. We can say that there are population determinants of efficacy. That again, immunogenicity in a US population is 10 times higher than it is in Africa, and efficacy is higher, and when we look at intermediate countries, we see that association. So this can't tell me, we really need a clinical trial to say what clinical difference could this make. But we're doing some additional modeling now. We're having a little bit of trouble getting funding for this second trial. You know, ironically, the sample size isn't even that big. It's in the 5,000 to 6,000 range because, again, these kids have so much rotavirus in the second year of life. So this is just a reminder that, again, particularly as scientists, you know, we love interventions that are 90% efficacious. But I like to say, if you have a vaccine that's 100% efficacious and only reaches 50% of people, you're really not doing any better than a vaccine that's 50% efficacious that reaches 100% of people. So it's really great that I can show you those maps in Africa and all the countries that have introduced, but we're really not reaching all the children. You know, we're doing very well in the Rwandas and the Tanzanias and the Ghanas of the world. We're doing not so well in the Angolas and the Malis and the Nigers, and you know, we need to do much better. It's not enough to color in the country. We really need to reach these kids. And these are just some pictures that I've taken. Nothing makes me happier than to see children getting rotavirus vaccine when I visit some of these places. A point I want to make, kids love rotavirus vaccine. It's the most fun study you can do, right? They're not getting a shot. They've only had breast milk in their lives. There's a little salt, there's a little sugar. You know, there's things that the EPI managers would not want to see. Here's a mother using the Rota vaccine vial as a pacifier, basically, for her baby. This vaccine could be self-administered. But here, to me, is one of the best things I saw. Not only does this child's immunization schedule have rotavirus, but it has IPV circled. And again, I am very hopeful that as we move to IPV, we will see better rotavirus response. So in the last 10 minutes, because Bill, I promised you I'd save some time for questions, I could really not deliver the Kirby lecture without talking about antimicrobial resistance and the role that vaccines might have. So how might vaccines help in our fight against growing antimicrobial resistance? Well, for one thing, the increased use of vaccines to reduce infection and inappropriate antibiotic use. So we did some population-based studies in the pre-influenza vaccine before we routinely gave influenza vaccine to children. And we saw that in the winter, 20 to 30% of all antibiotic use could be attributed to influenza infections, for upper respiratory infections, for acute otitis media. So that is clearly inappropriate antibiotic use. If we can prevent influenza, we're going to prevent that inappropriate antibiotic use. Similarly with rotavirus, I showed you how much rotavirus there is. You know, if you're in Africa, there are childhood standards for treating children with diarrhea with antibiotics because bacterial infections need to be treated. However, as I've shown you, most of the diarrhea is actually due to rotavirus. So if we can reduce the rotavirus, we'll reduce the use of antibiotics. We can develop vaccines against high-burden disease treated with antibiotics, and I think pneumococcal conjugate vaccine and its role in reducing acute otitis media in children. Now, there's an appropriate use of antibiotics, but again, by preventing the infection, we can prevent the use of antibiotics. I'm going to talk a little bit about this example, developing vaccines for diseases where resistance is a barrier to treatment, and my example will be typhoid, and then developing vaccines for diseases where pathogens are responsible for transmitting antimicrobial resistance, such as our enteric gram-negatives. Now, at the Center for Vaccine Development, many of my colleagues are working on vaccines against nosocomial pathogens, Pseudomonas, Klebsiella, Staph aureus. We have a lot of discussion with those vaccines about the market. You know, who is the population? What's the market value? You know, I was at clinical conference yesterday, and there was a case prevented. It's a prolonged, very costly hospitalization due to extreme antimicrobial resistance. I think any of you that work in a hospital can see how these vaccines could have a market value when just a single case, you know, can cost us hundreds of thousands of dollars and more. So what about typhoid? Again, I only have a few minutes left. I'm going to be much briefer here. But where are we in 2017 for those of you who might not follow typhoid every day? Well, typhoid does continue to be a substantial public health threat. We estimate about 12 to 21 million cases a year, anywhere between 150 and 200,000 deaths. Now, we know typhoid is largely underestimated, unlike diarrhea in children, where it's very simple to get a sample, and we now have very easy tests for rotavirus that can be done in the field. Typhoid is diagnosed with blood culture. As you might guess, the availability and accessibility of blood culture to most children in poor Africa and Asia is absolutely non-existent. And even where we have blood culture, we estimate it to be about 50% sensitive for typhoid. There's an increasing recognition of the burden in young children. We used to say it was a disease in Asia of school-age children and of adults. And again, particularly in Africa, and with more sensitive and use of blood culture, we are finding more typhoid. And think about it, you know, in children you get less blood, that makes the sensitivity of your blood culture even lower. So this has to be a real concerted effort to look for typhoid in these children. There have been outbreaks, if you've been following the news, there have been outbreaks throughout sub-Saharan Africa, big outbreaks in Uganda, in Malawi, in Zimbabwe, in Zambia. And we know that outbreaks affect a community much beyond the disease. They affect the ability of the healthcare surge capacity, which, you know, is essentially non-existent. And we know, very importantly, that antimicrobial resistance to the most effective treatments is on the rise. And the headline I show here is a current outbreak in Pakistan, where 400 cases have been diagnosed at Aga Khan University. This is the largest outbreak ever of multi-drug resistance typhoid. So we've seen increasing resistance for years. It's actually at about 97% in Malawi to chloramphenicol, to sulfa drugs, to ampicillin, to quinolones. But this bug is now also resistant to ceftriaxone. So you have healthcare workers in Pakistan having to use meropenem to treat typhoid in these children. Typhoid will soon become 100% fatal disease if we continue to see this antimicrobial resistance. The other issue is that we know, unlike rotavirus, the democratic virus, is that improvements in water sanitation and hygiene can eliminate or virtually eliminate typhoid. But we also know that these improvements continue to lag in many parts of the world. This map shows the percent of population with improved drinking water sources. This is from the WHO and UNICEF in 2015. As you might guess, blue is good and any other color is bad. It's really good for us to say we need improved sanitation, we need improved drinking water. It's actually quite hard to implement. So we are actually leading a new consortium with a nearly $40 million grant from the Gates Foundation to reduce the global burden of typhoid by accelerating the introduction of typhoid conjugate vaccines, particularly in low-resource countries. So as I said, we're the lead partner at the Center for Vaccine Development. We're working very closely with the University of Oxford and PATH. This is a multidisciplinary effort. We know that evidence alone does not lead to vaccine introduction. We need to build political will. We need to be able to communicate to countries. We need to help countries with surveillance and help them understand if they have a problem. And the reason we're in a new era for typhoid control is because we've had the licensure of a typhoid conjugate vaccine. This vaccine has longer lasting immunity, can be given at 9 months of age. The current typhoid vaccines aren't licensed until before the conjugate, 2 or 6 years of age, which means this can be incorporated into the routine immunization program. And we've had 2 major milestones just in the last month. The World Health Organization made a recommendation for the routine use of typhoid conjugate vaccines for endemic countries, and Gavi just last week pledged support for this vaccine. So this will be another vaccine that countries can implement at 30 cents a dose. The problem with this vaccine, so this looks a lot like my rotavirus goal, we don't have to inform policy and we don't have to inform financing decisions. This vaccine was developed by an Indian manufacturer. It was licensed on the basis of immunogenicity. So if countries have an outbreak, they are likely to implement, and this vaccine is now available, which is wonderful news. The problem is, for country decision-making, people are going to want to see efficacy trials. And so we are launching 3 large trials in Nepal, Malawi, and Bangladesh. We'll vaccinate anywhere between 20 and 43,000 children, and hopefully you'll invite me back in a couple of years and I can present these results. I'm really very pleased to say that the trial in Nepal kicked off about 2 weeks ago, the week of Thanksgiving, and these are some of the pictures. You see our tieback, there's participant diary, the children getting vaccine and getting their lollipops. So hopefully you agree with me that the public health value of vaccines goes far beyond the efficacy and the prevention of a single infection. That vaccine value may actually be higher where efficacy is lower. It's all about burden of disease, and we know that severe disease burden really drives vaccine policy. You know, I frequently have people say to me, well, you know, 50 to 60% is the glass half empty or the glass half full. And I say, well, that's not the question. The question is, what's the size of the glass? And if the glass is huge, then that's what matters. And for rotavirus burden, for example, it's a huge class. Vaccines can improve health equity, although I showed you challenges remain. Many of these, you know, we have a field site at the Center for Vaccine Development in Mali. We've had that field site for 20 years. It's very hard to reach children in northern Mali right now. So again, there are very legitimate political and security reasons, but we need to figure out a way to do this. And vaccines do have a role in fighting antimicrobial resistance. So thank you.